I'll look through your file, having no other information, and I will see what you had to say, and I will see what the parents are saying. And if it looks like, maybe you did blow it in some form, I'll say to the attorney, you might have a case here. Now the attorney is going to file a complaint. That complaint will go to the court, and that starts a 3 to 5 or longer year process of discovery. And discovery means now we're going to collect as much information as possible. We're going to interview in deposition a whole bunch of people. We're going to gather data, and then we're going to have a defense attorney and his or her experts, the plaintiff's attorney and an expert, or perhaps multiple experts, and there's a war that's going on. And it's all at that point motivated by the attorneys because this is how they make a living. 3 to 5 years of your life. What's the standard of care? What an expert has to do in reviewing your work is look at whether you did what was reasonable and prudent. Now, you can define those words as well as I can, but essentially they mean, what would the garden variety clinician have done relative to what you did? I can't hold you to do dialectical behavior therapy as well as Marshall Linehan does it. But if you're working with a suicidal patient and you did laxative treatment, my guess is one would say that's not reasonable and prudent. There's no evidence that it is appropriate or effective. There's probably no literature that says that this is even something with a degree of something we might call a reasonable practice. That's more than likely, if you have an argument to make that laxative therapy is a good thing for depressed patients or borderline patients, one of whom is now dead by suicide on your watch, that probably won't fly. That's a breach. If you didn't assess the patient for potential for suicide, or if your assessment really missed all sorts of cues, red flags were all over the place, and you didn't pay attention to them, that could be a breach. Your responsibility as a reasonable and prudent clinician amongst your peers is to assess patients, to reasonably formulate the level of risk, to reasonably establish a treatment plan on the basis of that formulation, to then implement that treatment plan, and to monitor how well it's going, and if it's not going well, to keep modifying it. That's what we do. That's what a reasonable therapist does. On the other hand, if you've had a patient in therapy for 5 years with no evident improvement and now they die on your watch, somebody's going to say, where were you? I mean, what were you thinking? Your job is to help patients get better. And if it's not happening, where's your reevaluation? Where's your another approach? Where's your referral to somebody else? But something that would show that you were paying attention. Because now, obviously, the patient died on your watch, but maybe you weren't watching. That's how an expert thinks about what they're looking at. Some experts at the same time come up with opinions that you're not going to be happy about. But they're experts, and sometimes they can be rather bombastic in expressing their opinion. So the more authoritative they sound, the more ultimately the court might believe them. You agree probably that if you're working with somebody in crisis or somebody who is suicidal, that you should be reasonably available to them if they need to contact you. Is that a reasonable behavior? How many of you carry a beeper? I got an N of 1. I had one case where the opposing expert, who was the plaintiff's expert, said that if you're working with somebody suicidal, you have to be accessible to the patient 24/7. The only way to do that is to have a beeper. Therefore, if you don't carry a beeper, you've breached the standard of care. I say, some experts will say the darndest things. But that's why you have experts on the other side to counteract that. But you don't want to get into this situation where somebody is going to say, basically, you didn't act like Superwoman. That's not reasonable and prudent. That's asking something that is way over and above what's reasonable and prudent. Nobody is going to be available 24/7. On the other hand, you probably should, as a standard of care, offer your patient alternatives because you're not available 24/7. So if you haven't said to your patient, I want you to call me if you're in trouble, but if you can't get through to me, here's what I want you to do. Now the question is, that might be a breach if you knew the patient was in crisis, particularly a suicidal crisis. If you're on vacation and you gave no alternative instructions to your patient, that would be a breach. But it doesn't mean you have to carry a beeper. When an attorney files a complaint, they make all sorts of statements. Some of them are they're boilerplate statements. They just come out of their files before they've even looked at the case or before they have an expert opinion. This is some of the things they'll say. Since the patient is now dead, it's clear that you did not protect the patient from a known danger to self. You should have known that this patient was a suicide risk, and you obviously didn't prevent their death. You obviously didn't adequately assess their risk. You may or may not have bothered to get past medical records, and most patients come to us with a history. And how could you ignore that history? Since you didn't reasonably assess for risk, you probably didn't develop an adequate treatment plan relative to that risk. But the last bullet there is the one that is most profound, and that is the charge, because your patient is dead on your watch, that clearly you lacked the adequate degree of skill necessary to work with this kind of patient. You weren't adequately trained. I just proved to you none of you were adequately trained. So it's an easy one to point a finger at and say, you know, maybe you're not as good as you think you are. And my job as an attorney is to really make that clear to the court, that you should never have been working with this patient in the first place. Am I getting anxious at all? Yeah.
Question. I've worked through a local hospital in the crisis department, and therapists have sent their patients over, and the patients will say, I don't want to go inpatient, there's nothing wrong with me. And if someone disagrees, they 302 them. They want to involuntarily commit them, but it has to be backed up by a delegate if it's not a doctor or the police. What happens then? What is on that therapist's shoulders if they did all they could and it still wasn't agreed upon by other physicians or the delegate? Or
Well, you just added in another dimension. If indeed I, as a clinician, believe that you need to be hospitalized even against your will, there are criteria that are defined by state statutes that I have to meet. You have to be clearly mentally ill. You have to be incapable of taking care of yourself and or a danger to self or danger to others. Now, I'm going to say, I think you're suicidal, I think you're a danger to self. Okay? Now, if I need to get that seconded by somebody and they don't agree, you have to have, if I'm in your shoes, you have to have a long note in your documentation that says, here's what I think, however, I can't get a second opinion to agree. Okay? But we're going to come back to that a lot. So let's go back to the question about whether you have the adequate degree of skill and training to work with suicidal people. I've already asked you about your graduate school training. Let's skip down to the variety of questions you could be asked. How many of you in the last, let's change this. In the last 5 years have read a book about adolescent suicide? 1, 2, 3, 4, 5. 5 people in the room have read it. Was it my book? Oh, I got a good book to recommend to you. 5 of you have read a book in the last 5 years. 5 of you. Could you tell me the title of the book? Without telling me? Do you know the title of the book? Do you know the authors? You probably don't remember much. How about in the last year, how many of you have read a research article pertinent to risk factors for youth suicide? Could each of you with your hand up tell me the authors of that article and tell me what the article said? Without telling me. Can you satisfy yourself that you'd be able to report that this is what I read and this is what I learned from it? It's very easy to make it look like you're not doing your homework. Very easy. 5 people in this room have read a significant amount, at least in the form of a book, about the subject matter, and now you have a patient of yours who happened to be an adolescent who's now dead by suicide. And you've read a book or haven't read a book for 5 years? This is the sort of thing that happens in a deposition. The attorney will build you up because you want to present yourself as if you know what you're doing, and then very quickly find holes and make it clear to the court by virtue of your testimony that you haven't kept up with the literature. Which is why you should read my book. Here's the good news. Basically, a very small proportion of these cases ever go to trial. Most settle, and some are thrown out in summary judgment because a good judge is able to read what's presented and recognize there's not a case here. But that 5 to 10% that go to trial, again, the last place you want to be is on a stand in a courtroom where you have a grieving mother bawling her brains out in the courtroom and her surviving children bawling their brains out in front of a jury because their sibling and her child died under your watch. The jury's going to be awfully sympathetic. It's not where you want to be. Okay, standard of care interventions. I've already mentioned these. Your job is, with every patient, to assess and formulate level of risk, to do what you can do to protect them from harm, and notably that means if they have a gun at home, to safeguard the accessibility of that gun. You can't safeguard every potential means to suicide. Ropes and ligatures are easy to obtain. Shoelaces will work. But you can do something about a firearm. You can do something about readily available medications that can be used in overdose. You can do something about knives if you had to, if you're talking to a parent because you're very concerned about their child. And that's what means restriction is all about. You need to make sure that somebody who's at risk because you formulated them to be at high and acute risk is not left alone. Because when somebody is severely troubled and suicidal, being left alone is like being in a Petri dish that grows bacteria that lead to suicide. Don't ever leave someone alone. You need to actively formulate a treatment plan, and the treatment plan first and foremost should be based on your functional analysis of this individual's motive or potential intent to suicide. If they've engaged suicidal behavior in the past, what led them to do this? What are the precipitating situations? Because those point to some points of entry, but they also point to vulnerable situations. So if a young person made an attempt to kill themselves after a fight with their parents, that should be part of your treatment plan. And that is, how reactive are they to their parents? Are we engaging family therapy? What am I doing about the potential for that? Because it's a garden variety event. How do I make sure that that doesn't lead, again, to suicidal behavior? No less what makes them particularly vulnerable to react suicidally to what looks like a garden variety event. So you have to really functionally analyze what's going on here and then have your treatment plan initially de-escalate the likelihood of suicidal behavior in response to a similar setting. Your first order of business is to decrease risk and, if necessary and possible, increase protection. And clearly decrease agitation, decrease the potential to act impulsively because one does not have good control. And that also means to make sure that alcohol and drugs are not part of the system. To implement that treatment plan and to be available and accessible as reasonable, and where you can't be, to make sure that there are alternatives built in. That's a very simple summary of good care with a suicidal patient. There are a variety of ways we screw it up, and we're going to talk more about these in different forms throughout the afternoon. Clearly, being on top of potential countertransferential issues is important. Suicidal people can make us anxious, they can make us angry. The more borderline they are, the more they're going to pull your chain in a variety of ways. And you have to be what we call a maypole. It's constant, steady, letting them do their number around you and not reacting in a way that potentiates their behavior in a bad way. So managing your response, be it hate, be it anger, be it anxiety, you have to manage that so it doesn't become part of their story. There is an awful lot that we know about suicide, and if you haven't done much reading, I urge you to get into the literature, because we know probably about 100 risk factors for adolescent suicide, and those are distal risk factors, chronic risk factors that make someone vulnerable, and each of those 100 have an empirical base to them. So we can trust that if indeed one has an eating disorder, there is evidence to say that increases risk for suicide. If indeed one has comorbidity, 2 or more psychiatric diagnoses, that dramatically increases risk for suicide. Those are vulnerability factors, chronic risk factors. But we also know a fair amount about acute risk factors. What is common to the last weeks and months of individuals who are already vulnerable? And so if someone is agitated on top of being depressed and having insomnia, now we have greater risk because that agitation is an acute risk factor. And the literature is replete with evidence-based data. But you got to read the literature. And that said, therefore, clinical intuition is not what you want to rely on. And yet a lot of therapists basically go by the seat of their pants or by their gut. I don't dismiss the idea that your gut is not informative, because I'm one of those people who says, if I feel like I have to go to the bathroom, something's going on between me and the patient. And I trust that that signals something, but now I want to tie it to what we know is supported by research. So my gut is nothing but a barometer. It is not intuition. It's just trusting that I'm responding to something. I need to figure out what that is. You want to be careful about what we call false beliefs. And in this case, we're going to talk, for example, about contracts. How many of you have used no suicide contracts with patients? Do you know that there's not an ounce of literature to support their value? Not an ounce? And there's a lot of reason to think that this is silly, that we do this, but 80% of hospitals use suicide contracts. It's mythical thinking, but people do this. Not a good idea. Want to be careful about burnout. We recommend, for example, you manage how many really at-risk or in-crisis patients that you see in any one week, if that's possible, because you still have a life to lead. You got to go home, you got to sleep, and you got to be able to function the next day seeing patients again. You want to make sure that you are in good professional shape, and you want to make sure that you don't think about working with suicidal people by virtue of seclusion and restraint. Yeah.
I'm startled to hear contracts don't work, but don't you think that's a good piece of paper to have in your record that you weren't reckless and didn't fail to notice this was in a very suicidal person?
Good piece of paper in your records is really important, but not contracts. And we're going to come back to the alternative later today, okay? We're going to talk a lot about documentation, because the more that's in your record that says, here's what I observe, here's what I think about it, and here's what I'm doing about it, the more after the fact, if you're ever in that position, at least you can say, that was reasonable based on the data I was working with. Documentation is the only way you can prove where you were 2 years ago. You can't do it by now saying, this is what I was thinking back then, because that'll be self-serving if you're in court. These are the common charges, the common complaints that are made in outpatient malpractice actions. That is where the negligence suit is against an outpatient therapist. Failure to properly evaluate the need for medication or unsuitable medication. Now, if you're not a psychiatrist or other medical doctor who works with patients at risk for suicide, you more than likely work collaboratively with somebody who prescribes medication. Hopefully you do. And we have a lot of literature that says certain medications are somewhat effective with certain diagnoses. We can argue all day about what that somewhat really means and the relative value of medication A versus placebo, but the literature will say that antidepressants, for example, are reasonably effective with depressed people. Okay? And now you have a depressed patient, and if you didn't either refer for a consultation or you didn't at least consider, will this patient potentially benefit from an antidepressant, and now the patient is dead, one is going to look back and say, well, surely this patient should have been evaluated for an SSRI. You don't want that kind of hindsight. You want to make sure that your records say, I considered it, and either I referred for it, or alternatively decided that this wasn't the way to go for the following reason. That's the rationale that's in your records for a judgment that you make. But if you fail to consider it, you're going to look like you don't know what the literature says about treating depressed people. The literature makes rather clear, combination of therapy plus medication. Makes clear that's the ideal. Yeah.
Is referral enough? So let's say you've assessed for medication need and you've referred back to the primary care physician or to a psychiatrist, but the patient says, I don't want to do medication, I want to do therapy.
Your documentation is going to say the patient refuses medication, and here's what we're going to do instead. That's fine. Okay? You're not expected to walk on water. You expect to think rationally and reasonably. We can't, as outpatient therapists, we can't force our patients to do anything. The average outpatient therapist sees a patient 1 hour a week. 1 hour. You know how many hours there are in a week? 24 times 7, that's 168. If you assume people sleep, give or take 100 of those 168, that's a lot, but even so, it's 1 hour out of 68. That ain't a lot of control, as they say. So you document, 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 document. Failure to specify or implement criteria for hospitalization. Keep in mind now, your patient has died by their own hand under your watch. And you didn't hospitalize them when 3 days ago they were off the wall symptomatically and talking about killing themselves. Looking backwards, one's going to say, why didn't you take more control over that patient you're not going to see until 67 hours later? Why didn't you get them in tomorrow at least? So you should have your own criteria for why and when you hospitalize, and you should hospitalize. But if you don't hospitalize and you have good rationale as to why, under conditions where otherwise the patient needs to be secured and safe and monitored, you better have an alternative. And the alternatives are fine, as long as your documentation says, here's why. The patient refuses to go to the hospital, the parents won't support a recommendation for hospitalization, therefore what we're going to do is the following. Fine. But you need to think about hospitalization. I can tell you there's not an ounce of research that says hospitalization helps patients who are suicidal. Can't find it. It does do some good things. It can calm them. It can initiate new medication trials. It can create a support system, sometimes with other suicidal people, good or bad. It can lead to alternative therapies. There are some outcomes that aren't bad, but there's not an ounce of therapy, not an ounce of research that says that will prevent suicide once at discharge. And some patients even are capable of suiciding in the hospital, so it's not a guarantee. Failure to maintain appropriate boundaries. I'll pick an extreme example. You're a 40-year-old male therapist and you have an unbelievably sexy 18-year-old patient, and somehow you get caught into a sexual relationship with her, and then she kills herself. Now, you ain't going to look good when the time comes for that family to sue you because she told her friends that she was sleeping with you. So there are things called dual relationships, and they're not all sexual, that you have to be very careful about, and those are defined by your ethical standards in your profession's ethical guide. But you don't violate the ethics of your profession, because if the worst happens, you are going to be basically dead in the water at that point. And I've had cases where therapists slept with the patient then killed herself. So it happens. Failure to evaluate suicide risk. Now, the typical therapist evaluates suicide risk in the following way. Are you thinking about suicide?
Yeah, I've thought about it.
Are you thinking currently about suicide?
Yes.
Okay, that's going to lead then to a series of questions, because she said yes, about what kinds of thoughts, what her intent is, does she have a plan, etc. Okay? If she said no, however, are you thinking about suicide?
No.
I'm a little concerned because you've been depressed, you've been not sleeping well, you've been drinking more than usual. A lot of people who have those kinds of behaviors do have even fleeting thoughts about suicide. You don't have any?
No.
That's the end of the assessment right there. That's the typical assessment. And typically that second level of question would never get asked. If you say no, end of assessment. That's not good behavior. But that is what the average clinician does. So I might in court have to say, at least you asked. And that's better than some people who don't ask. Failure to ask. Now the question is, do you ask when you first meet the patient? Always. But you should also ask at other times, particularly when there's a transition. I'm going on vacation. How are you doing? Any thoughts about suicide? I work in a hospital, and it's July, and we've got a whole new set of residents coming in. There's going to be a little instability here. How are you doing? ... You should ask whenever there is a sign from mental status or a sign relative to anything else that something other than status quo is present. Ask again. Don't need to ask every session. Doesn't hurt to ask every question. How are you doing? Any thoughts about suicide? Make it part of your vocabulary. Because at least it says, again, under the worst of circumstances, I paid attention to this every time I saw this patient. Is that next door? That's next door. Failure to at least attempt to get past treatment records. Most adolescents who come into treatment come in with some track record of being in trouble. Trouble may mean psychiatrically, it may mean in terms of behavior. You should always do your damnedest to get whatever history there is sent to you. Now, I can tell you things have changed because of HIPAA. It's damn hard to get things sent to you. People claim that they don't need to send it or they're prevented from sending it, which is not true. But you should at least demonstrate that you made an attempt to get it. And if you don't get it in writing, you should at least say if you can carry on a phone conversation about what was Jane doing when she saw you in therapy 2 years ago. Tell me about how she did. Tell me about conditions of termination, etc. Was she suicidal at any point in time? What was going on? You should at least make an attempt to get that information because history does repeat itself, and the more you know about history, the better prepared you are to assess now. Failure to conduct a mental status evaluation. That's the only way we have to assess current symptomatology and current upsetness and current poor cognitive control is to do an MSE each and every session. Your notes should reflect you paid attention to the patient's presentation and you asked questions. Failure to have a formal treatment plan. Your documentation should say, here's what's going on with this patient and here's what we're doing about it. And again, if it doesn't look like we're doing well, here's what we're going to do to change it. Pay attention to a treatment plan that is consistent and follows your assessment of why the patient is seeing you. Failure to safeguard the outpatient environment, which again speaks to attempting to control available and accessible means to suicide with a patient who you've documented as at risk for suicide. And this is not a failure, but this is what will kill you if you have it written down as far as the opposing attorney is concerned, it didn't happen. Because now I got you in a legal situation, of course you're going to do everything possible to defend yourself, and you're going to say whatever you have to say happened 2 years ago, because you have to defend yourself now. If you didn't document it contemporaneously with seeing this patient back then, as far as the court's going to be concerned, you're making it up. If you're in a hospital setting, you know about JCO, and you know about sentinel events. And sentinel events have to be reported to JCO, and the events are recorded. And as you see up top, there have been 857 reports of suicides since 1995, and that makes it the fourth most commonly reported event in a hospital. And the main reasons that are described as contributing to suicide are listed from 1995 to 2000 and more recently. And what you see is first and foremost in both time periods is patient assessment. That means looking back, the hospital has defined that the patient was inadequately assessed for suicide. And that's in a hospital. We have all these forms that outpatient therapists don't bother with. So even in the most restricted of environments, patient assessment is the number one issue. Then you have physical environment showing up between 50 and 73% of the time. And that means, for example, the patient hanged themselves and there was an available hook and an available ligature. Or that means that a supply closet was left open and so the patient could ingest a lethal amount of cleaning fluid. Orientation and training, that means that there's no evidence that the staff were trained to policies and procedures and or trained, in this case, to suicide risk. So those are the common observations relative to JCAHO's sentinel event system. And these are the common legal cases. And again, what you see is failure to properly evaluate for medication or unsuitable medication. Secondly, failure to follow policies and procedures. That's why training is important. Failure to implement hospital safeguards, such as removing sharps or having unsafe premises, etc. Failure to treat or treat appropriately, and a big one now is improper discharge. What's happened over time is that we have gone from being able to hospitalize someone for 2, 3, 4 weeks down to maybe 3 days at best. If they still talk about thinking about suicide, we can keep them in. But if they stop talking about suicide, if they deny thinking about suicide, and they're sleeping okay, and we've started them on medication, you can't keep them in anymore. So we have to discharge. Now, the question is, what happens at discharge? Is the family involved with an adolescent? They should be brought in and they should be told about ongoing monitoring and observation. They should be told about monitoring the home environment for accessible means to suicide. They should be told to be compliant and adherent to recommendations for outpatient care. An outpatient therapy appointment should be scheduled before discharge. It rarely is. It's usually just handed to them on a piece of paper, call Dr. Smith. That scheduled appointment should be within 3 days, maximum 7 days, because the majority of suicides will occur right away. There are lots of things that should happen that they don't, and that's why we have improper discharge up there. And that's the data. This is from studies in Denmark, the United States, and I forget what Chang was, but international studies. The average composite odds ratio for suicide occurring within 1 week after discharge from hospitalization, psychiatric hospitalization, 278-fold increase in suicide. Yeah.
Is this for youth or all age groups?
This is all age groups. We don't have anything that's specific to youth. Even over the last 30 days, still dramatically increased odds, and over the last year, still 30 to 60 times greater. Now that shouldn't surprise us, that those at great risk for suicide are those who had risk for suicide. They were depressed. They looked better in the hospital, which explains why they got discharged. They didn't stay very long, and they don't have much in the way of supports and resources post-discharge. When do you document assessment? First time you see the patient, anytime there is any evidence of suicidality, when there's any noteworthy clinical change in the hospital, before you make some different kind of disposition, and immediately before discharge. At all times, document the instructions you've given to patients about firearms in the home. And with regard to adolescents, document your discussions with the parents. There's a lot of literature on the importance of not having accessible lethal means to kill oneself. And there is evidence-based prevention programs that have documented that training the parents in the importance of removing accessible firearms will indeed produce good parent behavior. So you should do something with somebody who's been suicidal to make sure that it's not easy to act in a moment of impulse. And if there are no firearms or parents don't agree or whatever, make sure you're documenting that you had the discussion and here's what happened. In a typical documentation, you're documenting your evaluation of risk, your rationale for coming to that evaluation, and again, the treatment plan that's designed to lower the risk. Here's an example. 16-year-old high school student, first episode of major depression, denies current ideation, but still is at moderate to high risk for suicide because, and here is the observations that say why I'm still concerned even though they denied thoughts of suicide. Doesn't want to be hospitalized. The plan is to see him 3 times a week with daily telephone calls on the other days and to consult with his parents and immediately refer for medication and reassess in 1 week. That's a 1-paragraph good note.